When evaluating an elevated mean corpuscular volume, the most common clinical reflex is to strictly follow the automated number. But a study of over 4,000 patients revealed that in 90% of cases, the actual etiology of a macrocytic anemia would not have been predicted by the MCV alone. The automated MCV provides an average, but it is mathematically blind to the cellular architecture. To establish a true diagnosis, you have to bypass the machine and look directly at the peripheral blood smear. This left panel displays megoblastic macrocytosis. DNA synthesis impairment produces oval-shaped macrocytes alongside hypersegmented neutrophils containing 5 or more lobes. Compare that to non-megaloblastic macrocytosis on the right. Here, the macrocytes are perfectly round, and the neutrophils maintain a normal structure without hypersegmentation. Finding round macrocytes shifts the differential away from B12 and folate. But before analyzing specific non-megaloblastic conditions, you must clear 2 preliminary diagnostic checkpoints. The first is reticulocytosis. If a patient is bleeding or experiencing brisk hemolysis, the bone marrow correctly responds by pumping out erythrocytes. Their presence elevates the average MCV. A diagnosis of true non-megaloblastic macrocytosis requires you to definitively rule out both megaloblastic morphology and an appropriate marrow response to blood loss. The second checkpoint involves spurious laboratory artifacts. These are physiological conditions that actively trick the automated cell counter into calculating an artificially massive cell volume. This schematic shows cold agglutinin disease. IgM antibodies cause individual red blood cells to tightly clump together in cooler temperatures. When this aggregate passes through the aperture of an automated analyzer, the machine misinterprets the entire cluster as a single enormous red blood cell. Because this macrocytosis is an illusion of temperature, the clinical fix is immediate. Warm the blood sample to exactly 37 degrees Celsius to break the agglutination, and then simply rerun the test. The second major artifact trap on hematology boards is severe hyperglycemia. When serum glucose levels are exceptionally high, the sample mixes with a standard diluent, acting as a hypotonic fluid. Water rushes in, causing the red blood cells to rapidly swell before measurement. Board examiners use cold agglutinins and hyperglycemia to test your situational awareness. They want to see if you can differentiate a true cellular defect from an environmental testing error. Missing these specific artifacts leads directly to ordering highly invasive, painful bone marrow biopsies for marrow failure syndromes that do not exist. Once artifacts and reticulocytes are excluded, the workup focuses on the 2 most common drivers of true non-megaloblastic macrocytosis: alcohol use disorder and liver disease. This peripheral smear reveals the pathognomonic pattern of hepatic dysfunction. You will find the expected round macrocytes, accompanied by target cells showing central pooling of hemoglobin, and stomocytes, characterized by their slit-like central pallor. Those structural changes represent general liver disease, but the morphology shifts again when the hepatic dysfunction becomes profound. The emergence of acanthocytes, or spur cells, acts as a severe morphologic marker. Their spiked membrane projections point to end-stage lipid metabolism defects driven by severe liver failure. Alongside the hepatic pathway, hypothyroidism acts as a secondary, often clinically silent etiology. Unlike the dramatic volume shifts seen in megaloblastic processes, thyroid-induced macrocytosis remains mild. The cellular volume expansion is subtle. Because the presentation can be entirely hematologic, checking a TSH level is a mandatory step in every unexplained case of non-megaloblastic macrocytosis. Liver and thyroid pathologies account for the majority of these anemias. Their morphologic signatures on the smear are distinct, and critically, their capacity to expand red cell volume is mathematically capped. That volume cap creates the central algorithmic trap of macrocytic anemia, a heuristic built entirely around upper limit thresholds.
This chart plots the diagnostic zones. Isolated alcohol use and liver disease rarely push a red blood cell volume beyond 114 femtoliters. That number serves as a strict ceiling. Consider the classic clinical vignette. You have a patient with documented severe alcohol use disorder, presenting with an MCV of 122. Attributing an MCV of 122 to the alcohol use alone is a diagnostic error. The volume has breached the physiological limit of hepatic macrocytosis. An MCV crossing 114 femtoliters in an alcoholic patient strongly signals a concurrent, hidden megaloblastic process superimposed on the liver disease. The moment that 114 ceiling is broken, you must immediately order serum B12 and folate levels to locate the secondary deficiency. The diagnostic algorithm has one final extreme threshold, the 130 femtoliter mark. An MCV exceeding 130 femtoliters almost exclusively narrows the differential down to frank megaloblastic anemia, or severe toxicity from drugs that directly interfere with DNA synthesis. There is an inverse to this trap. If a patient has concurrent iron deficiency, which shrinks cells, alongside a B12 deficiency, which enlarges them, the opposing forces can mathematically average out. The MCV normalizes, completely masking both deficiencies. The MCV is not a continuous spectrum of disease severity and is a rigid set of quantitative thresholds that dictates entirely separate clinical interventions. We now pivot to etiologies that directly disrupt marrow production, causing an elevated MCV, but notably failing to produce the hypersegmented neutrophils of a classic megaloblastic process. The primary pharmacological culprits are hydroxyurea, azathioprine, and methotrexate. These agents directly interfere with DNA synthesis, stall without the full megaloblastic morphology seen in vitamin deficiencies. Beyond pharmacology lies the most critical can't-miss pathology in the elderly population, myelodysplastic syndrome. The classic clinical profile for MDS is an older patient presenting with unexplained macrocytic anemia coupled with additional cytopenias, like thrombocytopenia or neutropenia. The peripheral smear confirms the clinical suspicion through specific dysplastic markers. You will see hypogranular neutrophils lacking their normal cellular contents and pseudo-Pelger-Hewitt cells identified by their abnormal bilobed nuclei resembling a pair of glasses. The detection of rare circulating blasts on this smear is a definitive red flag, marking progression towards severe disease and acute leukemia. While the smear and cytopenias raise the alarm, they cannot confirm the disease. A formal bone marrow biopsy is strictly required to lock in an MDS diagnosis. Unexplained isolated macrocytosis in the elderly must be treated as a precursor to marrow failure until proven otherwise via strict morphologic review. We can now synthesize these thresholds, artifacts, and morphologies into one rapid-fire diagnostic decision tree. Step 1. Check the reticulocyte count. Rule out physiologic red cell expansion driven by brisk hemolysis or acute bleeding. Step 2. Rule out automated counter artifacts by verifying sample temperature for cold agglutinins and checking for severe hyperglycemia. Step 3. Examine the peripheral smear. This strictly divides the pathway into megaloblastic disease with oval macrocytes versus non-megaloblastic disease with round macrocytes. Step 4. Apply the 114 femtoliter rule. If the MCV is under 114, you target the workup on liver disease, alcohol use, and a TSH check for hypothyroidism.
Step 5. If the MCV exceeds 114 femtoliters, particularly in an alcoholic patient, you immediately pivot to investigate a concurrent B12 or folate deficiency. Step 6. If you identify unexplained cytopenias in an elderly patient, you bypass the benign etiologies entirely and proceed directly to a bone marrow biopsy for MDS. Mastering the approach to macrocytic anemia does not require memorizing endless lists of theoretical causes. It requires strictly defending these exact algorithmic tollgates against laboratory illusions and cognitive bias.